I always appreciate an introduction. I always feel like I should wish my mother or my kids were here to hear that, because they just, my kids in particular, just know that I'm not home a lot, and they would just, I think it would be interesting for them to know what I do. One of my daughters said recently, she goes, "Well, Dad, you used to be a doctor." I said, "Well, I still am, but it's hard for them to understand sort of when you move into administrative roles and you're trying to shape the system. It's kind of hard to get your concepts or constructs around that." I would like this to be fairly interactive. So I've got a slide deck that I actually used just last night over at Johnson City Medical Center as we meet with our physician-organized delivery system as we bring accountable care to this region. So I'll go through some of these slides, give you some of the broad concepts about what we built. I know there's, from the title, I want to make sure we touch on informatics. So if we're getting a half an hour or so into this and I haven't really touched on how informatics plays that and that was your real purpose, don't be shy. Raise your hand. Feel free to throw questions out at me. Let's make sure this really hits the questions that you may have come with, and we make sure we get those answered. So let me give you just a little bit of background about what we are. As Amal mentioned, we have a great health system here in this region that has really created its own burning platform. And what I mean by that is we've got Mountain States Health Alliance, traditional hospital system that has pulled together multiple hospitals as they've struggled, trying to create a more efficient healthcare system. They continue, just like many hospital systems across the country, struggle with creating economies of scale and efficiencies within a multi-hospital system across a region. But despite that struggle, they also realize that the game is changing in healthcare. And now more than ever before across the United States, we are seeing a real, I think, revolution in healthcare. And I think you're on the front end of that. I think as public health students, I've been at some meetings over here at ETSU, very impressed that the leadership here at the school is trying to figure out what should you as graduates and undergraduates be prepared to do as we go forward? Because I think there's a tremendous role, and we'll certainly touch on that, for students like yourselves to come out and really help accountable care. And this approach to population health. So Mountain States created two business verticals underneath a for-profit subsidiary, which is a little bit unique, right? So you've got a not-for-profit health system. They create a for-profit subsidiary, and they create two companies underneath that. One is Anew Care Collaborative, meant to have a management team that works with physicians and providers to promote population health management and accountable care. The other is Crest Point Health Plan. So if you've been in the community, you may have seen advertisements, especially in the fall. Crest Point Health launched a Medicare Advantage health plan for seniors. That's an important dyad that most health systems have not done, although we're seeing it a little bit more increasingly over the last year. A lot of health systems have realized that accountable care puts the business of health systems, hospitals in particular, at risk. Right? Because right now they get paid on the number of people that come through the emergency room and the number of people that get admitted to the beds. That's the bread and butter of a health system. Accountable care aims to change the dynamic and get primary caregivers in particular and teams around them, which is where I think you will come in, hopefully, teams around them to really work with patients at a different level, at a community level, at a personal level, and get them to think about what they should be doing differently, make sure that the health system is meeting their needs. I would argue that a lot of when we say that patients are non-compliant or non-adherent to therapy, I would argue, given my experience, that most patients, it's not that patients really want to be unhealthy, it's that our systems fail them. Plenty of seats up front. Please come on down as you come in. I would argue that it's our systems that fail them. So if our systems had better approaches to that care, the patients could be successful with what they do. Why do I say that? I say that because it's been very few patients across my 20 years now in healthcare and practicing for more than 10 years of that, where the patient would say, "No, doc, I really don't want to not be healthier. I don't really want to lose weight. I don't want to stop smoking. I don't want to do what I'm not supposed to do." Most patients really do want to, right? But we're stuck in the constructs of how we were raised and our environment. It's hard to break old habits, so patients need help, and our systems don't do that very well in healthcare. So accountable care is designed to get the physicians back at the forefront of that. Something called the Patient-Centered medical home that we'll touch on a little bit is a concept that really gets the primary caregivers back in the forefront. It's a term that came out of pediatrics back in the 70s to deal with complex children. I'm a pediatrician, so I know the model well, practiced under the model. I believe it does work. It does actually help patients stay healthier or in better management of their disease or their chronic illness. And in doing so, it keeps them out of the hospital, keeps them out of the emergency room, keeps them out of the hospital from an inpatient perspective, and it saves dollars. So it's more labor intensive on the front end in the community, It requires teams of people in today's ever-increasing complex healthcare environment, but nonetheless, it can really work. So Anew Care is an ACO, Accountable Care Organization. CMS, federal payer, launched a program about a year and a half ago, and there's been 3 waves now of accountable care organizations that CMS has deemed appropriate to take on the managed care risk or the total cost of care for the Medicare populations it serves. That's not the only definition of accountable care. If you walk out of here with just a couple pearls, one of them, I hope, is that accountable care is really a population health approach to all patients in a community. So you've got Medicare patients, that's one slice of an accountable care's business. Okay, although many accountable care organizations right now, that's the only slice they're focused on, is the Medicare population. And the concept is if we can get them under the management that we were just talking about, take care of them in a better way. Medicare is willing to say our patients typically cost a certain amount of money per year, and that number keeps going up. We'll actually commit that amount of dollars to the system. If you can start, you providers, if you can start to change the way patients use the system and hopefully cost less, biggest thing is going to be hospitalizations and ER visits at first. If we do that, we'll share in the savings because we know that there's been no downturn of our cost of healthcare, right? You guys know that well. So we've seen this increasing rise. So if we can start to change that curve, CMS is saying we'll actually share in the savings with the providers. And they've put the hospitals really at risk for this model because the current system still pays fee for service. So if accountable care, if Anew Care is successful in managing our patients better, creating quality, good patient experience as well as cost efficiency, where does the savings come from? It comes from the parent organization that's formed us. Mountain States loses admissions and ER visits and makes it harder for them to make their bottom line. So it's a very interesting burning platform, going back to that initial comment, that Mountain States has created. We're not the only ones. This experiment is being played out across the country. It is not easy. Daily, we have conversations. In fact, I'm missing one right now to be here. That was called over the weekend about, how do you do this? How aggressive do you get in going after patient populations as we build these new models of care? Because there's a lot of infrastructure that the primary care base in particular really needs help on. These are the 2 business verticals, as I mentioned. Our network is pretty broad, just to kind of give you a broad scope of the Anew Care Collaborative Network. We have hundreds of practitioners across the Northeast Tennessee and Southwest Virginia area, along with a lot of other ancillary providers, and those become incredibly important. If you think about home health, skilled nursing, DME, which is durable medical equipment, laboratory, rehab facilities. If you think about the complexity of a patient, especially the Medicare population, all these things become important. We need providers in all these segments to start thinking differently about how they work with patients. We need to get everybody aligned around the total cost of care and managing that efficiently while maintaining quality or improving it, and not just how many patients can I run through my segment of healthcare, which is the game we've been playing in healthcare for the last couple decades. When I stand in front of physicians that are sort of new to this concept, because especially in primary care, physicians are busy. If you've spent any time in a physician's office, you know this, right? We have waiting rooms, which is a tremendous, if you think about a lean system, if you've studied lean systems in business, you know that an idea of having a waiting queue is really a failure, right? In healthcare, we need to start thinking of our waiting rooms as a failure of how we do work. That's pretty radical, right? Most people don't think that way. We kind of even still build hospitals today with waiting rooms as part of the design. But we've got to think differently about how we manage. So if we're talking about a group of physicians like I did last night about why they should fully engage in this effort, what are our options? Given the changing reimbursements that are coming, what are our options as physicians and public health folks and anybody else in healthcare? We could do nothing. We could allow the fee-for-service to continue to play out. Where is that going to get us? We're going to see increasing cost pressure and price pressure, where the big insurers as well as the federal government are going to start to now say, no more. We're not going to give you the increases even though you say that that's what the cost of healthcare is. We're going to force you to start to get efficient. So if you don't do it ahead of time, we'll force you to do it by just cutting rates. And we're already seeing that with the sequester, right? We're seeing, in fact, there were many physicians, there was an article I read just the other day on March, I guess it was Saturday morning. They were wondering, the writer was wondering why the healthcare communities didn't cry more about, make more noise about the sequester going into effect on March 1st. Anybody have an idea why? No, it affected them. Actually, Medicare payments get cut 2%. Hospitals and providers actually get cut. The reason is because there was some discussion right up into the week that preceded it that 2% wasn't enough, and that 10% on the military was too much. So there was some discussion that if they had struck a deal in last week before the March 1st deadline, that probably healthcare's rate of decrease would have gone up 2, 3, 4%, as opposed to, and in military and some of the other programs that have been cut or that are currently under sequester may have actually been relieved. So healthcare sort of breathed kind of a little bit of a sigh of relief, believe it or not, even with a 2% across the board cut on the Medicare spending. We really need to start thinking differently and get providers and hospitals thinking differently, and many are, thankfully, and they're trying to sort of take destiny in their own hand, and we need to start thinking about more of a shared savings model. That's exactly what Medicare has put out in front of us. So they're trying to seed the thought of innovation in healthcare as a major payer, right? Medicare is a huge program across our country. A lot of dollars flow through it. Some people sometimes ask, especially at your level, but even providers, why does the federal government care so much about the spending in healthcare? Well, it's not just Medicare. It's also the support they give to states for Medicaid. It's also the employees of the federal government, including the military. When you add all those up, some estimates say that the federal government pays for more than 50% of Americans' healthcare. So we already have, in some ways, a somewhat nationalized system in terms of a single payer that really, even though it's made in different buckets, they're out there really caring about this rising cost. And as the cost goes up, and we were having this conversation 10, 15 years ago, we thought that 11 and 12% of the gross domestic product was too much. Here we are now at 17, 18%. That means we can't spend money on other things, right? Education and other things, military, whatever it is you believe we should be doing, social programs. So now it's become, I think, we're finally at a tipping point. And so we're at this point where Medicare has stepped in and said we should do Medicare shared savings. They've got over 250 healthcare organizations, including our own, 3 here in Johnson City, Tri-Cities area, that are basically participating with the Medicare shared savings program. And the concept, again, is here's the total payments that we expect for the population that you manage, tens of thousands of lives. We know that the trajectory has been going up at 7, 10% plus per year. If you can now bend that curve and hold that cost steady and find margin under that curve, we'll share in that savings. So it used to be, since they pay fee for service, if we had saved money and stopped, basically visits to emergency rooms and inpatient facilities, federal government would save the money. If we do that for a Blue Cross patient, Blue Cross saves the money, right? They've already collected the premium. Medicare is trying to change that and say we can incentivize you to think differently about that. And eventually we get to this point of outcomes-based population health management, where I happened to be in Washington, D.C. This past spring, and it happened to be the day before the Supreme Court ruled on the ACA, right? Whether it was sort of legal to do what the federal government was trying to do. And the group I was with, I was still at Blue Cross Tennessee at the time, and there were 5 representatives that were brought to D.C. from the 5 Blues plans that were represented to basically, their seats up front. Feel free to come on up, doesn't bother me at all. There were, if you work with physicians, you have to get used to them coming and going, so it's not a problem. So the meetings we were having, one of the meetings we had was with senior staff, bipartisan, both Republican and Democrat, senior staffers, House Ways and Means, Senate Finance, Commerce, and Energy. These were behind closed door sessions. They weren't public. The public hearings had already been held. And they were still wrestling, even the day before the Supreme Court ruled, wrestling with this healthcare cost, wrestling with how to fix a system that's got runaway costs. And we talked a lot about these types of programs, shared savings programs, bundled payments for specialists. We can talk about that this morning. The idea of medical homes and getting primary caregivers incentivized differently. And as we talked about that, I left Washington that day with sort of 2 key talking points. One is I actually felt better about our federal government than I probably have since I was a Boy Scout in high school. There's actually real work going on in Washington. It is bipartisan, and they were actually trying to get something done. So despite what we see on TV and what gets the newsworthy events, there's actually a lot of people that really care about the country and getting it fixed. And what I saw was Republicans and Democrats finishing each other's sentences. They were working hard on this problem. The second thing that I left with, though, was the sense that this outcomes-based population approach to value-based payment is coming. Medicare shared savings is just testing the waters for regions like ours to see if we can manage populations differently. So what they're basically saying is, we're going to test this, we're going to see some success and some failures, we're going to learn from it, we're going to keep promoting this approach. And what they're ultimately going to do is they're going to come to a region like this, and Anew Care has about 13,000 Medicare lives under it right now. We'll probably get closer to 20 when a couple additional groups join us. There's a couple other accountable care organizations that also have between 20 and 30,000 members. If you add those all up, let's say the Johnson City, Tri-Cities area has, I don't know what the right number is, but let's say for sake of ease, 100,000 Medicare beneficiaries across the region. Medicare eventually will come to a region like this and say, here's 100,000 beneficiaries. They cost us, I don't know what the right number is, $100 million a year. The number's bigger than that. But here's the check. We're willing for the next 3 years to give you a contract, you as a healthcare system, this amount of money based on traditional cost. We'll increase that amount each year for the next 3 years by the consumer price index, right now running, I think, about 3%, right? So not 7-8+ % like healthcare typically does. And in fact, by years 3 or 4, if you're doing well, we'll extend it for years 4 and 5, but years 4 and 5 will be CPI minus 0.5%, because we want to start getting the control of this cost down in relative terms to everything else we spend money on. So CMS, I think, is leaning that direction. They're trying to get us ready for that. Are there examples that exist already with that? There are. In fact, part of my career I spent working for a company that was doing healthcare in correctional markets, working directly with state governments, and basically that's how we got paid. It was a global capitated rate to care for a population that you knew had a lot of illness and chronic problems, including mental health, and we had to manage the care under that curve. We only succeeded with multi-year contracts because the first year there were always surprises and there were always care costs that were higher than you expected. By years 2, we were typically doing okay, and by year 3, we were finally recouping some of the losses from year 1. So the risk was completely shifted off the state budgets to us as a company, and we were able to succeed in that market. We weren't seeing double-digit profit margins. Okay, they were lean, but the method does work. Now, there were some interesting lessons in that market, though, because it was a captive population, right? We were dealing with correctional patients, so they were inside of state jails or state prisons or county jails. They typically, if we treated them well, with respect, as we tried to get our healthcare providers to do, right? We weren't there to worry about their correctional issues. We were there to worry about their healthcare. If we treated them well, they came, and we could see them as frequently as we needed to, right? In some cases, that wasn't very frequent. In some cases, it was. But that idea of managing the population and touching the patient the right way is a critical building block of population health management. So as we think about population health, it's a shift from, you've probably seen slides like this, the patient in the middle of a paradigm of healthcare where they have to basically themselves navigate through inpatient facilities, outpatient facilities, specialists, primary care. It's transactional, right? For any of you who've used healthcare, you know you get a bill for every touch you go, right? Wouldn't it be nice if you got one bill for anything that you dealt with complex? Think about something complex that some of you may be dealing with, and instead of getting a bill from the primary care and the specialist in the hospital and the outpatient radiology facility and the lab facility, wouldn't it be nice if a healthcare system started to bundle that all together and said, if you come to us for a certain amount of care, let's say diabetes or a certain procedure, this is your fee. Just like walking into Best Buy. This is your fee if you want this, right, service in this package. That's what we need to get to in healthcare, and that becomes sort of this other diagram, which is the concentric circles, where the person sits inside of a medical home, primary care-based team approach to care, right? They'll get reached out to not only by the physician, but more likely they'll actually interact more time with the nurse or perhaps public health students that are actually interning, which I hope to have more of in the near future. And you'll be interacting with patients to sort of help them along their journey to do what they should be doing for their health care. And then that becomes part of a physician-organized delivery system. So occasionally that patient will have needs to go to a specialist or an outpatient facility or have a procedure. That gets coordinated with the same team that's back at the medical home. And then you have a broader regional approach, so that as you need things that are even broader than just that sort of smaller circle you spend time in, you've got coordination across an entire region of care. And perhaps even to centers of excellence that sit hundreds of miles away. Right? There's some people who would argue that perhaps certain rare conditions, rare procedures, should only be done at centers of excellence. And those might be one per state or not even one per state. So, it may be that you'll have a healthcare system where someday you can say, look, you can go here for this procedure. There's a risk for that. We really recommend, and the cost is a little higher when we do it here, we really recommend that you actually go across the state to an academic medical facility or some other center that's doing this really well. They do hundreds of these a year. We'll pay for your airfare to get there because the cost is cheaper, because they've got more efficient systems, so we could actually afford to pay for you and a loved one to go with you. We'll put your loved one up for a hotel room the night before, and that's still part of the overall package, and you can go to that center of excellence. So that'll all get managed, though. You won't be left on your own vices to have to do that. The care system will wrap around you and do that. If you think about so how do you get there? Right, so I created this slide. I don't necessarily like it, but it kind of tells the story. So if any of you are graphically artistic and want to help me create a better slide, please step forward. But what I tried to convey to some of the senior leadership in Shadow Mountain States was this is a journey, and it's an evolution of thinking as you think about what's often referred to as care models. If you think about chronic care, I think it was back in around the 1960s or 70s, there were some authors that started talking about care models for chronic care, and they basically were saying there's a standardized approach that should be given for chronic disease, right? And that should be something, if 100 different facilities do things 100 different ways for the same disease, they all can't be best practice, right? So care models by design is meant to be an evidence-based process that is really the best way to do things. Once we identify where those are, there's a lot of great work that's been done nationally in a lot of centers. We don't have to recreate this wheel. In fact, this isn't even proprietary information in many cases. We're hoping to have an affiliation here in this region with a large academic medical center soon that will help actually sort of dump hundreds of care models in our lap for us to look at, decide which ones we are okay with, and we'll just bring those to the community providers and say, look, this is what's been deemed best practice at this center. Does it make sense for our region? If it does, this becomes the standard. Care models have, by design, measurement criteria built into them, both process and clinical outcomes, and that allows us to then think about how we measure success against the adherence to those care models as providers. So care model is the evidence-based protocol, creates accountability, okay? That alone doesn't do it. We've known best practice in healthcare, right? Some of you have probably seen the writings that say 10 to 15 years before best practice makes its way into healthcare mainstream, right? Why is that? Well, it's because of what's in this cloud, right? Which is somewhat nebulous, because you've got to put the right people and processes in place to make those care models just a normal way of doing business. So you've got to think about different people that are added to the system, to the physician's office, care coordinators. When I was at Blue Cross, I helped to launch 80 medical homes across the state of Tennessee with primary care providers. Blue Cross was sponsoring that event and paying some of those bills. The care coordinator was at that time an LPN or an RN put in the practice to sort of go prospectively out to the patients as opposed to the reactive nature that most practices operate in. So practice, I used to be in practice, I would see 40-something patients a day. They were the ones that called us. We were busy enough by what came into our office with the thousands of patients that we cared for. But the problem with that model is there are patients that have real needs that sit out there. They don't call the primary caregiver. They don't call the specialist. And they wait until they get themselves into trouble, and then they show up where? The emergency room, and they wind up getting admitted. It's a high cost. So the system, that's a system failure in my mind. So what we're trying to do here is the care coordinator using technology, using IT, electronic health records, disease registries, web-based decision-making tools. It's not, when you look at some of this technology that's starting to come out, it's not all that convoluted. It's relatively simple algorithmic thinking, but it allows a caregiver, if I deploy 100 care coordinators, isn't it nice that I know I can have a tool put in place that allows 100 of them to do the same outreach every time? Records it, captures clinical data, social determinants of care, et cetera, et cetera. The nice thing about that is, and the important lesson there, the point for that, second talking point, second key pearl for you, that type of technology enablement, I believe, starts to allow us in healthcare to challenge who does the outreach to patients in the community, right? And that's a thought that, if I share that in physician and nursing circles, gets a lot of people nervous real fast. And the reason is they feel a threat to their own job security, right? They, for many years, have been the only ones who could reach out to a patient and say, Mrs. Jones, what's your hemoglobin A1C if they're a diabetic, or what's your blood pressure today, right? We've not traditionally allowed non-clinically trained people to do that. But I would argue, my own kids, probably as bright, hopefully as bright as all of you sitting here, could easily do that as part of a coordinated care approach. So I think as we think about public health graduates and students coming out of college and graduate schools with clinical orientation, but not necessarily clinical degrees, maybe it's a lot of the public health folks that really start to think about this population health management differently, and maybe you guys are really really best prepared to potentially be these care coordinators in the future. Now, the systems have some checks and balances. Why is this something that I can feel confident is the future? Because if you get into an algorithm and you're going down and you're checking off a variety of answers, the system can automatically bump it up to a nurse or a doctor, depending on the answers to the queue that you're working through, right? So you can do a good job of counseling, behavioral modification techniques, and other things that get patients engaged, but when you find out the patient with congestive heart failure has a 10-pound weight gain today, all you really need to know is that that's a problem. So hopefully but the system will also know that that's a problem, and that'll get bumped automatically to a nursing queue to deal with, right? So, you'll learn why that's important, but you don't necessarily have to know why CHF happens and all the dynamics of the heart. You just need to know some of the clinical symptoms that are normal or that are warning signs, right? As we work through that cloud and we actually get that in place, then that creates the coordination. We have to work on dissemination of these models, which creates education. Right? Adult education, very different than undergraduate education. Trying to get providers who've been doing something a certain way for 30 years is a little bit more challenging sometimes, right, than it is to have somebody with a clean slate thinking about a new paradigm. We have to get these models in front of them, get them to change their practices potentially, and then we get their engagement and we start to get consistent practice across the community. And as we do that, we get best practice across the community, we get more cost efficiency, and we start building sort of the arc of more efficient, accountable care, and that allows us to be successful under these sort of bold, innovative payment systems that are going to come. Let me pause there. Does that make sense? Nodding.
Great idea.
Makes sense, right? Okay. It's not my idea. It's just I'm just here.
Well.
But it is sort of a great spot to probably pause and just sort of then talk about how IT fits in, because I know part of the title here was about informatics. So critical to this whole success factor is information. Right? As a physician or a care team, really more importantly, physicians I think will still, especially primary caregivers, will still lead teams of people. But the primary caregiver today, if they're working full-time, 50 plus hours a week in a practice, probably cares for about 2,500 to 3,000 patients. That's about a full-time equivalent practice, okay? So the future is that, and we know we don't have enough primary caregivers by many people's estimates, right? More people have gone into specialty medicine. The future that is probably that primary caregivers will have to start thinking about taking care of 5,000, 7,000, 10,000 patients. Not by, of course, working 150 hours a week or more, but by having a team around them that helps to outreach. When I was in practice, and I practiced, I think I said, for over 10 years, there was a great article that came out of Denver Children's. I'm a pediatrician by training. And what it said, I thought it was a great article at the time. It made me rethink the future of what I was going to be doing in healthcare. It threatened a lot of providers. What it said was that 85-90% of a pediatrician's day could be done by a nurse practitioner or a PA. I would argue it's probably you don't even need those folks to do probably half of that other work. The reason why that's a threat, of course, at the time, pediatricians thought, wow, if the model changes quickly, right, I'm going to be out of work. Well, the reality is we've seen primary care ranks continue to fall. I think that same percentage probably can apply to internal medicine and family practice. My colleagues, I'm sure, in those disciplines would argue vehemently that that's not the case. But I'm going to argue that it probably is true, because most of what we've done as physicians, in terms of annual physicals, which is now being questioned as to whether the value of those is there. Some of us were questioning that 10 plus years ago. All of that really could be done by others, right? What you really need to be able to do is manage the masses by using technology platforms. All of you. I think I could probably train many of you pretty quickly to sort of reach out as a first pass to a diabetic population very easily, using an algorithm, using technology that you're very familiar with, using an iPad or equivalent, and sit there and go through a series of checklist questions that the system now is capturing as information. What is the patient's weight? How are they doing on their diet? What's their hemoglobin A1C if they've gotten a recent lab test? What's their daily blood sugar? And as you click through all those questions and you input the data, the system, as we said before, does a few things. It helps to recognize those patients that are outliers. Who are the patients that are about to get into trouble? And if we're doing that prospectively, we don't no longer have to wait for the patient to show up in the ER because they've now crashed or had a problem with their disease. We now start to identify the signs early. And we start thinking about getting that patient in to see a nurse or a doctor and get them cared for. Right? So again, the models are going to change. This is just a graphic that just talks about the fact that these new payment models really do have some value for everybody, all the stakeholders. And this is what starts to make it different than the capitated markets from back in the early 90s. I thought I had a clock up here. Just give me a high five if I'm okay. As you think about the capitated markets in the 90s, one of the problems was it was all about cost containment, and we had no IT systems in place to help us really measure quality, or if we were doing the right things, right? So what we don't want to do is create a system where by doing less, right, some physicians used to joke under capitated markets in the 90s, if I just close my office door and talk to patients and prescribe everything by phone, I can make 2, 3, 4 times what I typically make in the course of a year or two. The problem is many of those patients are going to start to have problems and start to wind up in the ER, and it's actually not good care, right? So the trick here now in the future is really to figure out what patients need to be seen by the physician, which patients can be actually outreached by a number of extenders and team members across the team, and then how do we make sure that that patient experience also is improved? Right? How many of you have gone to a physician or access to health clinic, you don't have to raise your hand, and really not felt wowed by the experience? Right? Probably the majority of you. We need to change that in healthcare, right? We need to think of ourselves as a service industry. And again, accountable care keeps that as one of the key metrics. So even if we save money in Anew care, Medicare has said, so for the Medicare population, Medicare has set a standard that says we will not share in those savings with you unless you meet certain quality standards and patient satisfaction standards. That's a fair way to be assessed, right? So can we manage the costs? We have to work on that. Can we maintain clinical quality? Do patients get what they should, the right process measures? Are their clinical outcomes improving? Are we actually seeing key metrics for disease compliance show themselves to be improving? And if we do that and the patients are pretty happy with the experience, then we should get paid those bonuses in healthcare, right? And primary caregivers actually stand to potentially do far better than they've done traditionally in terms of pay scales, as well as the teams that are wrapped around them. The payers can also do well here, right? Why would Medicare care about this? We already talked about that. If they can flatten their curve and actually start to decrease it, even if we decrease it far faster, they know they're willing to share the dollars in because they've at least started to cap the problem. Why would a payer like Blue Cross care about this? Well, if Anew Care as a system of care, as a population health management team, can manage a population better, Blue Cross can price that better for the marketplace. There are plenty of employers that will still want Blue Cross insurance, right? They're one of the best brands in the country. And by doing that, we can give them a fixed price for multiple years. They can turn that around to product for consumers and commercial clients, and they feel like they've won, right? So the purchasers on the individual exchanges are sort of the next big wave, right? So as a patient, we want to have good satisfaction. That's important. We want to feel like we've had good quality measure, and would it be nice to have transparency around that? But we also want to know that we might be able to pay. So some of you, 30,000 or more patients probably in the Tri-Cities area come 1/1/14 will be part of the individual exchanges. So we will come to healthcare as individuals, no longer represented by, you're all probably under a student plan if you access it, but there are plenty of people who have no access to a plan through their employer. They have no access because they don't quite qualify for Medicaid. And right now they're sitting in that sort of middle that Obamacare has fixed, right? So the exchanges come to us with a game-changing play as well. Now an individual will start to come to the markets as an individual consumer. What are the things that are important to you as an individual consumer? It's going to be the same in healthcare. If you're going to Best Buy or you're looking at electronics, right? Some of you are more pressured on the cost piece, right? I have a son who's your age. He goes and builds his own computers and goes online and finds components and does it for half the price that I can. I can't do that. I don't have the time to do that. I know I'd mess it up. So either I go to him and pay him as my consultant to do it, or I just go to Best Buy, tell the guy what I want, and I pay the service. And maybe I pay more, but I'm willing to pay for that service quality that Best Buy will give me, right? So consumers come to the market with different interests. Healthcare needs to be able to relate to that. We know there's going to be a lot of price sensitivity because the stipends that the federal government gives individuals on the exchanges will be on the low end. So in order to have something that makes sense to us that we'd want to buy with those stipends, we're going to have some low-priced insurance models that allow us access to probably narrow networks. Gets back to this concept that Medicare is pushing, right? If I try to give you a network that has everybody in Johnson City and the Tri-Cities area in the network, all physicians, all specialists, all hospitals, that's a pretty expensive network to manage. I have a hard time as a leader getting all those components aligned, right? Not saying we're there yet, but we're working. But in Anew Care, I've got one health system. I've got a handful of providers that are big groups, pretty well known, and I've got some specialists that are also in there. They're all committed to working on this paradigm that we're talking about. And because of that, I can price that network at a much better band to think about the totality of your care, and it's a better price point. So everybody wins in this model. Let me take a quick second and talk about transparency. Because one of the things that's really missing from healthcare is the ability for you as an individual consumer or as a member of a health plan. If you've got, I assume there's probably some kind of a student health plan that you're part of. You probably just, maybe you or your parents just signed off on it and you're just part of it by default. And this is how my son does it anyway. But you probably don't give it a lot of thought. Well, here in the next few years, you'll probably start to have the option to do that. It could be that as a student of the university or employees of the university or an employee of Mountain States, that we are no longer giving choices of a health plan. Here's your health plan, here are the places you can use. It might be that employers even come to us and say, you know, we're going to get out of the health insurance business. And an employer is going to come to us as individuals and say, we will now give you $8,000, $10,000 for a family coverage, which traditionally costs them more than that. Or they may give us what it costs us. Maybe it costs $12,000. They'll give us as an individual $12,000, has to be used for health care, you can't use it. And we'll give you that $12,000 and you have to go to the individual markets to decide what you can buy. And I'll be given choices on the exchanges federally here in Tennessee of choices that I could tap into because my employer's not covering me, right? Those will be probably lower cost options, but they'll be somewhat limited, although there'll be benefits that have to be in there. But there'll also be private exchanges where some of the big benefit consultants that work with big companies across America are looking to create these individual exchanges that are private that allow me to say I could go to the federal exchange and get so much for this much money and actually save a little bit of my money. And if I do that, my employer does agree that once I buy the insurance, if there's some left over, I get to keep it. Okay? Or I may go to the market and say, boy, I really have a child with a special need, or I have something that's going on that really wants, or maybe I just want a certain level of service. And I really want to know that I can go to a certain hospital in this market if something bad happens. I'm willing to pay an extra $1,000. So that cost is $13,000. And I'll have to pay $1,000 out of my own pocket plus the stipend I'm given. So the individual markets are going to be transformative in healthcare. What do we need to be successful as consumers on that? We need information. So a big part of what Anew Care is working towards is informatics that creates information, not only for us as providers. So we're putting in place Truven Health Analytics, which is a platform from Thomson Reuters Company that allows us to take all the quality data that we can grab, and we're going to be working on creating connection points from practices, put that into this informatics engine, but also take consumer information in terms of patient satisfaction, and then also claims information about cost. So we'll create a number of views with this analytics platform, and this is where the dollars come in and the investment has to be made. It's why this is hard work, but it will be transformative. I'll be able to give my physicians in the network performance report carding, for lack of a better term, that'll show how they're doing against quality metrics and patient satisfaction metrics, as well as cost metrics for total costs of care. So if I touch a patient with diabetes, and I have 100 of those in my practice, I'll start to have a view by the end of next year that'll show me as a practitioner how many of my patients have gotten all the process measures that they should have gotten, all the things that they should have gotten. How did my team and I do on getting them all those things they should have done, compared to my peers, compared to national benchmarks? How did I do with the outcomes? Right? One of the metrics in diabetes is a hemoglobin A1C. It's a chronic measure of compliance with therapy. How many of my patients have normal hemoglobin A1Cs? And how does that compare against my peers in practice, the region, and nationally? How am I doing with patient satisfaction? I may be doing great clinical care, but if my satisfaction of my patients isn't very high, right, that's a risk for me as a provider that those patients may pick up and go elsewhere because they care about the service component of it. And then most importantly, how am I doing on cost? Not most importantly, but important for the sake of being successful. How am I doing on the cost? If the average cost for diabetic care on an annual basis is $1,000 and I'm spending $2,000, how long do you think I'm going to be asked to take care of diabetics in this population? Probably not very long. Now, we have to risk adjust that. We have to make sure it's not just on 100 patients. I would argue it could have just been one patient that got really sick. That would skew that. So we've got to be careful to make sure we're not using too low of numbers. But nonetheless, we can start to show all that type of data, and that's where we're moving pretty quickly here in the next couple of years. And the informatics platform that we put in place is critical to the success for physician measurement. Once you have that information in there, everybody else could see it as we turn on the switches, right? So there's a capability that we will have to flip on a patient portal that allow you as a patient that are seeing Dr. Lundquist to see how do I do. You may be a diabetic. You come to me. You see how you're doing, but you can see how all my diabetics are doing in aggregate, right? You won't be able to see their personal information, but you'll be able to see that Dr. Lundquist cares for 100 patients. Here's how he does. Here's the cost. And you'll be able to see that, here's another doctor across town who's got better satisfaction and does actually all the patients are healthier, and maybe I need to go see that doctor, right? And that's going to become important for things that are non-elective or non-urgent, non-emergent. So if, let's say, some of us get up in age, right, as the gray hair comes around the temples, I got a family history of a lot of knee replacements in my family. At some point, I'm probably going to be shopping for a knee replacement, right? And if I do, how do I start to look at the surgical technique, the cost that I'm going to have, and the cost out of pocket? So I may have bought an insurance plan that was more expensive on the front end that has less out of pocket, so it gives me, I can go anywhere and it's not going to cost me very much. Or I may be on the health exchanges and have a very limited benefit that says for a knee replacement, I get $15,000 for the total episode of care. Everything from 3 days before I go into the hospital to 90 days after. That's all I get. So I'm going to go to a surgeon and I'm going to say, how do you do on that? I'm going to look on the metrics. How are you doing? How much do your knee replacements cost? And if they on average cost about $15,000, okay, I can play the odds and probably do okay. If I do everything I'm prescribed as therapy afterwards, I can probably stay under my deductible. Better would be that surgeon comes to me and says, we guarantee the price is $15,000. Right? We know some patients will cost more, they'll have complications. We know others will do better. And if you do these things for us, go to physical therapy, do these things that you're supposed to do, we will guarantee that we will charge you no more than $15,000. That's the future of healthcare. That's a bundled payment. Okay, that's the concept of bundled payments around healthcare procedure. It's really easy on surgical specialties, but you could start to do that even for diabetes care. So you could get a system like Anew Care, married with a hospital system like Mountain States, saying to you as a patient with a chronic disease, congestive heart failure, that the average cost for congestive heart failure patient costs $20,000 a year. Not everybody gets admitted, but some do. That's part of that average cost, right? But the range could be anywhere from $5,000 to $150,000. If your insurance plan says, we'll give you $10,000, once you exceed that, it's your dollar, right? The health system has to come up with a method to be able to say, we can manage your care. If you do these things, if you see your physician, listen to your care coordinator when they call, when the public health students from UTSU call you, you've got to take their calls. You've got to work with them on the answering the questions. As you do all those things, we will guarantee that your overall care costs are covered. Right? And then Mountain States, Anew Care Collaborative, take that global payment for that care, and we have to make our margin based on the fact that we provide quality care, efficient care, patient-satisfied care, right? And all those things. So let me pause there. How much time do we have, Amal?
We have about 25 minutes.
Okay. I've got more slides. I can bore you with that, but let me pause there, and I'd rather see some maybe use these last 20 minutes for more of interactive. What makes sense in this model? Challenge the model. Throw out whatever beliefs. What I love about college students and graduate students, when I have done this periodically, is you guys usually don't mince words. So tell me why I'm crazy. Tell me, what's your fear? What's your, what are you mad about in healthcare? Questions? Go ahead.
When you're talking about the extenders for physicians, and then basically the electronic health record, based on the input data, it will boost them up, then you just see a nurse or a doctor. Would you do that through telemedicine, or would you actually have them come into a facility?
Yeah, it could be. I think we have to be real creative about what the future holds, right? I always use my son as an example. And, I think my son, he's doing computer science. He jokes about the fact that he doesn't like to be out in the light. He's kind of a night owl. And I think my son would be happy if he could live his entire life and never step foot in a physician's office. Okay, and God willing, he never will have to, right? Because he's very tech savvy, as many of you probably are. And I think he would look at the world and say, boy, if I can have a camera sitting here or my iPhone camera, and I can interact with a care coordinator that way because they have to be able to see a rash that I can send them a picture of or whatever it is, done. Treat me that way. If I can be on the phone with you and just be answering a bunch of questions that you're entering in a database, does that fulfill my need to give you the information you need to manage me as a patient? As long as I talk to you once a week or once a day or once a month, then I fulfill my end. He'd be happy with that. So I don't think it has to be a visit. I think we have to challenge ourselves in healthcare to say, why do we have to see a doctor once a year? Right? I'm a doctor. I don't do that. Am I a bad patient? Maybe. There's things I should do for my health. I know those, right? But that doesn't mean I'm unhealthy, right? I've gone to those visits, and it's typically a waste of 3 hours of my day, getting there, waiting, coming home, and I'm not told anything I didn't already know, right? So I think we have to really challenge who needs to see a physician, who needs to see a nurse, who needs to see an extender of a team, And who really can be left to their own devices? Even a diabetic who's managing their care well, if they're getting their blood test twice a year and it's perfectly in control, and they're sending through electronic means their daily glucose charts for an information system to quickly look at and say everything's in compliance. The hemoglobin A1C is the check against that, right? Are they just giving me the right data? Well, the A1C, you can't lie with that. They're going to get their blood test. I'm going to know if it doesn't match up. The computers can tell us some of that and basically tell us to manage by exception. Manage those patients who need the touches. I think we have to challenge ourselves. Telemedicine, though, is a great opportunity for healthcare to also transform itself. When I was doing the correctional healthcare market for 5 years, one of the patient populations that was most troubling for us and for me as a chief medical officer was our hepatitis C population. Right? We had a lot of patients who had drug histories and they had hepatitis C. Managing that consistently is critical for a lot of reasons. One is, who do you treat and when do you treat? How do you be consistent? If you don't do that well in a highly litigious population, you get sued as a company, okay? So we have to make sure we have a consistent approach to care that's based on whatever the state's model was for what they were willing to do. If we didn't treat them the same, or if we treated them the same, we treated them variable, and we didn't follow them up for side effects, it was real problematic because the drugs have very significant side effects. And, and there was just the issue of just making sure you were doing things the right way. I wanted to be able to show that we had quality programs for this. So the way we solved that problem across 6 states was I had one physician, an internist, not an ID specialist, but an internist who had a special interest in this population. She never probably would have worked inside of a correctional organization, right? She was not willing to walk inside the walls, right? But she really had a passion for that disease in the population. She became, I think, an expert in the field and still practices today in that same role. I'd probably put her up against any infectious disease specialist on hepatitis C worldwide because she's been treating hundreds of patients every week in multiple states with hepatitis C. And she does it by a consistent approach. She does it either directly with the patient because she's licensed in both the state she sits in as well as the state that she's practicing in, okay? Sometimes it's just she and the patient. Sometimes it's she and the patient and the physician or nurse from that facility because they're trying to learn a little bit more about the care of this complex condition. Sometimes it's the physician really is at the site is taking primary, but she's in the background, checking labs, checking adherence to the protocols, making sure that nothing's going through the cracks, right, falling through the cracks. And occasionally she'll find an abnormal result. She'll make a phone call to the physician saying, hey, not trying to bother you, just happen to see this result was abnormal. Did you and your team see that already? I think we should make some adjustments to the medications. The doc might say, yep, caught it. This is what I did. She goes, great. Or, no, thank you. I didn't see that yet. We'll get right on that, right? So it's that kind of a system where telemedicine can just really transform the way you get specialized care to the rural population. And I think, the cameras now on iPhones and, a lot of the portable technologies we have, just 5-10 years ago, we were paying $10,000 for telemedicine sets up that now you can almost do with an iPhone connection. And the iPhone can have, ability to capture blood pressures and glucose. There's little gadgets that allow for bloodless or, without breaking the skin, monitoring of your oxygen saturations if you've got chronic lung disease, your glucose concentrations if you've got diabetes. We can do some pretty amazing things with technology. And as that price comes down, it finally fits into this model, right? When it's too expensive, it doesn't add up. But home monitoring, I think, will also transform it. I can foresee a day where certain patients will may never leave their home if they don't want to, and we'll care for them all there. And as long as they have some exercise capabilities, we won't have to force them out of their home, right? If they can show us that they're doing some of the things that they should be doing.
Dr. Lundquist, please repeat the question for the sake of it.
Happy to.
Maybe a long question to repeat. You started off talking about every patient wants to be healthy and
Most.
over our upbringing and environment, which these guys here in public health on a daily basis almost. We preach that, which we call true community health, population health. But it seems like the model addresses population health as the hospital population of patients. How do we change the system or the clinicians from thinking of the population health, community health as educational initiatives, environmental modifications, and not sort of lab reports of one patient at a time.
Right. So the question was really about the difference between population health or hospital-centric care, if I can just sort of summarize it that way. I think it's an absolutely excellent. So the model of accountable care is really population community-based. It's thinking about those behavioral factors, the social determinants of health, the needs of a patient in a community. I didn't talk about attribution for the Medicare population. The attribution is not hospital-centric, even though the hospitals are supporting these models because they're, frankly, I think most hospitals, most of the ACOs across the country in CMS's demo are hospital-centric models, right? The hospitals are paying the bill to get this started. The reason is they're afraid to get cut out, right? They're afraid that providers move without them, and eventually there's massive sways on who's going through a hospital. I mean, frankly, I think that's part of why they're investing in this. But it's still a burning platform nonetheless. So the attribution, though, is at the primary care and specialty level. It's at the community level. So that's capturing, from a Medicare perspective, it's payer-centric, right? It's who's paying the bill for what patients, and how do we change the way we get those get those patients through the system. We could do that for multiple payers, and we know in our country we'd still miss 30 million, 40 million uninsured lives, right? So even if we did Medicaid, Medicare, private insurance, right, we'd still miss a subset. Well, Obamacare is going to close that gap, but it's not going to get completely there. And I think the other attribution factor that we've got to do at a population base, right? So if a new care is successful, hopefully in a couple of years we have Medicare patients, Medicaid patients under global fees. We've got commercial payers. We've got lots of health patients coming as individuals in the aggregate, become a group, right? Bringing their total cost of care dollars to us to manage with them. There's going to be uninsured lives. I think the health systems that are seeing the uninsured that are still out there will have systems in place to try to capture those and assign them to an ACO. And as a community, let's say they don't fall, let's say they completely fall through the cracks and they don't have any of those other access points. I would argue that it's still important for a health system working with an ACO to figure out how to manage that. The hospital might want to pay, or the community might want to pay, for the care of those few patients that fall outside. But more importantly, I think what we're going to see is the closing of the loopholes over the next 5 to 10 years. It'll take a while, where even those patients who fall outside of the current programs will have some ability to apply for those programs. And the fact, if the federal government gets it right, they will increase the penalty for us to be uninsured, right? Because the system really only works if everybody's in, right? You've got to spread the risk across the entirety of the population. So I think what we'll see is the federal government will start to raise the penalties for staying outside of the exchanges or not accessing health care insurance, so that eventually the penalty becomes higher than the cost of the insurance, and therefore it becomes a no-brainer that everybody should have it. I would like to see the federal government take it a step further, right? There's certain things that we have to do as citizens, right? Some people choose not to, but we have to pay taxes. We have to, I was reading an article the other day, they're talking about the draft and selective service and how women probably need to be added to that, very highly controversial topic. But basically, there's certain things we have to do. Wouldn't it be interesting is if in order to get health insurance on an annual basis, every one of us from a certain age, probably sometime, eventually we'd probably starting at a college level, we had to file an end-of-life care plan. There'd be not-for-profit, multiple ways to do that. There'd be national databases where once you filed it, they're not telling you what to do. Federal government's not saying you have to choose this or this. They're saying go to this site, or one of these 7 sites. They're going to walk you through all the questions about what you might want at end of life, whether that be now tragically or 60 years. You can go in and change it as often as you want, as life circumstance changes, but you have to have it on file. Why is that important? Right now, a lot of care costs occur at end of life, and a lot of people have not said what they want. So if something tragically happens to me, and I just had a riff over, Thanksgiving with my kids, and they weren't home, and now they come out, and we're still in a tense moment, and Dad's sitting in an ICU, and they've got to make a decision about my end-of-life care, right? My one daughter's wrestling with the fact that she fought with Dad a couple months ago, and we didn't reconcile. And my son's going, he was a nice guy, but get him off the ranks, right? So, they're fighting about this. We should have a plan. Well, sorry, kids. We understand that you guys have issues that you're working through as a family. We have counselors that can help you with that. We have your dad's care plan. Here's what he wished. If something tragically happened, and this and this and this were the case, which is the case, this is what he wanted, right? The nice thing about that kind of a plan from a public health perspective is it allows the person's wishes to be carried out. And when you think about it, right now, if something tragically happens to any one of us, health systems are designed to do everything for every one of us, right? That may or may not be what everyone wants. So at least let's take the people who don't want that from that happening, right? It saves money. It allows us to take the wishes of people. So, did that answer your question?
Well, but once everyone's covered, let's say we're 5 years down the road or 10, and everyone has a plan at home, are those ACOs going to do something to go back to the root of the problem in education and environment? And is there something in the model that hints to that?
Yeah, no, absolutely. From the get-go, right? The whole idea of care coordinators is if I have a chronic condition, I've got to engage with my condition and the care coordinator. So I'm getting that. If I'm overweight and I've got a family history of diabetes, right, it's not going to be good enough for me. There's going to be penalties that I'm going to start to face. And we're already seeing this being tested with employers. The price of insurance is going to go up if I'm not doing what I should be doing to try to manage my weight, my health.
Is there something there before you become overweight? How do we keep people from becoming that? True prevention.
Well, if I had the answer to that.
Is there anything built in there leaning towards that?
Yeah, no, I don't think you can do that just with the accountable care organization. I think what you're really talking about is a societal discussion, right? And that really becomes where the intersection of healthcare and public health and community planning and all that comes into place, right? I think it's an important component of it. I think it's even far more complex than just healthcare, which is complex enough. But I think that where there is an intersection with healthcare is in an accountable care global payment methodology. If I know that an elderly lady has a falls risk, part of the plan, let's say she comes in and hopefully before she even breaks her hip, part of the plan will be for one of my care coordinators or a public health agent or somebody to have done a home visit at a certain age to identify fall risks in their home. And because we're being paid globally, I can actually pay to get rugs tacked down or pay for things that are non-traditional health care that create a safer environment that prevents that fall from happening and therefore a multiple-day hospital admission downstream. So it allows us to think differently about how our healthcare dollars are spent, and then that certainly intersects with then community planning and other things. We start to think about as a nation, as a community, we can start thinking differently about what we should be building into our communities. So I think they intersect, but it's tough. Yes?
I see all this on the healthcare side. What is being done on the patient side? How are we educating them on that and bringing them in? We've got to bring them in to assess all this. How are we doing?
Yeah, so the biggest thing is the interaction, right? So there's, on the front end, as you have information, as consumer information becomes more available, right? There'll be, I think, public campaigns both regionally and nationally about how to read that information, learn about it. There'll be websites that'll be there for people who can use those sites. But some of those will just be interactions, right? So if you're newly diagnosed with a certain condition, our care coordinators will reach out to you. Some of you may be reaching out to patients to help with that education. We sent you the links. Did you get a chance to look at them? Okay, if not, well, let's walk through that. What didn't you understand? What's very interesting to me is patients, and it's happened over the last few decades, physicians used to be sort of trusted advisors, and patients would ask them just about anything. Increasingly over the last few decades, I think because there was a sense that the doctor was too busy, which is a shame on us, right? But it was sort of the way the payment systems encouraged us to see more and more patients per day. Patients stopped feeling comfortable asking their doctor a lot of questions. Not everybody. Some people still spend plenty of time doing that. But some people, I remember when I was doing pediatric calls, sometimes, my wife, a lot of friends of our families would call because I see them in the office and I'd be on call, or they'd call our house and they'd get my wife on the phone. Don't bother your husband. He's probably really busy. I know he had a busy day. What do you think about it? And they'd ask her. She's not clinical. She's not a nurse, right? We happen to have 7 kids together, so we've got a long history of raising a lot of kids. But they would ask her, and she had heard me on the phone call, hundreds of times, and she would basically sit there and get in my eye view, and I'd kind of go to get up, she'd go no, and she'd say whoever she was talking to, so I could kind of remember, and she'd basically kind of repeat what they were saying, and then she would give her advice, and I would sit there and go, yep, right on, exactly. Right? You're right on spot, right on, and. Again, so I don't know why people do that, but I think what I found though is the care coordinator role is far less threatening for some reason for most patients. So when you start engaging patients on a more frequent basis, but with a care coordinator or a nurse, most people see that very satisfying. So we actually can get pretty good engagement around their healthcare issues, and we see some very good results in the early stages of these models starting to evolve. So I think getting patient engagement and involvement, I think, is doable, but we have to think differently. And I think we need a trained workforce that really understands behavioral modification techniques and understands the social determinants of healthcare. One of the systems that I had put in place at Blue Cross that we had piloted that I hope to bring here in our New Care Collaborative was a web-based tool, as I mentioned. And the care coordinators, to their credit, forced us to add a bunch of questions about social determinants of care. Why didn't you go get your medicine? And they had drop-down menus that we kept building on. We've got to be able to understand that people, if they can't, just because saying to somebody, go from ETSU to Johnson City Medical Center to you and I hopefully seems pretty simple. Well, for a certain patient, that may not be such a simple thing, right? They may not have a car. There may be other limitations that they have. So we've got to know those things to help people get through those barriers that they have that we may not even perceive. So I think technology can help us remind ourselves to ask about those things, but the interactions, I think, can change the dynamic.
And a lot of patients are getting confused. I mean, the place that I work is an ACO. And we're starting to bring it. The patients are really confused. They don't understand why they're getting this new paperwork. How do you explain that? Are you, your company, are y'all doing something?
Yeah. Well, it's probably the same thing as yours. I mean, it's one patient at a time. If somebody's confused, try to put systems out that sort of blast information out, but then you try to follow up with patients. I don't think there's a magic bullet to that question. There's no simple answer that's going to solve it all. I think we've got to learn about our patients, just like the retail environment knows, right? I don't know how many of you are internet shoppers, but it's amazing. Not always right on, but increasingly, right, the various web sellers can target emails to you and make you think you need something you didn't even think you were thinking about, right? They start to get a profile about you. Well, those databases are out there, and the big insurance companies, I don't know, still Blue, we were talking about creating access points to that so that we can understand the retail nature of individuals. And that's important because I might like to get an email and prefer that. You might prefer a phone call. You might prefer a text. So how do we make sure that we're targeting our messaging the right way? Somebody else might want paper, right? And it's not necessarily just based on age, right? There's variations in different age groups, but you're going to see differences across that. So we've got to get better at understanding the retail nature of consumers so that we hit them with the right way of learning. I think back to my own medical school days. I actually would have done a lot better probably with less classroom time, some classroom time, but more study time. Johns Hopkins had a tremendous amount of classroom time. It was the number one in the country for the amount of hours we spent in class. I actually probably would have done even better had I had more self-learning time. And I've learned that about myself since, becoming an adult learner. But, I think we'll see that in education too. I think we'll see these kind of changes occurring in the educational domain.
So are you guys going to eliminate the paper trail, or what are you doing to eliminate the paper trail?
I'd love to. I've tried to force myself to travel only with my iPad when I go out for meetings now. It's not always possible. It's hard. It is hard, right? You guys have seen that too. But I think we're going to get better at that. I think as our electronic health records become more robust, as we create patient portals that allow them to have snapshots of their data that they can manage and take with them, whether that's and a direct connection back to their electronic health record. And most importantly, we create the pipes of the health information exchange, will create portability. And I think we will start to see an improvement in that area. I think we have already, right? Digital X-ray saves thousands of dollars per facility now, per year. So as the cost comes down and as the connectivity improves, we'll get there. That's the goal.
Okay.
So.
I think we're close to the end of our time. I hope that everyone in this room enjoyed this presentation this morning as much as I did. I hope you leave this room with a renewed energy and excitement, about the positive changes in healthcare that are coming, down the pipeline. I hope you enjoyed the questions.
Absolutely.
I do want to thank, a few individuals this morning. I want to thank Ms. Janet Stork and Nate Cunningham, who did a fabulous job setting up our breakfast. Dr. Stutz for bringing your students. Thank you. All of our faculty in the back of the room for your support. E-learning for recording the presentation. LivePath for the support of the live streaming. All of you students for being here. I hope I didn't forget anybody. Remember, first Tuesday of April is our next breakfast with the expert for this semester. So I hope you can join us here. And of course, a big thank you to Dr. Lundquist. This is a certificate of appreciation from the department and a small.
Thank you very much. Appreciate that. Thank you. Thank you.
Any closing remarks?
I wish you all luck. I would tell you become educated consumers in healthcare, right? Really push the envelope on learning about what is available to you and continue to push on that front. And hopefully we see you all out there as part of the accountable care organizations of the future. And it's an exciting time to be in healthcare. It really is. As frustrating as it is for those of us who may, make a living there at one hand, it's incredibly exciting to be part of the transformation of the American healthcare system. So I encourage you all to stay involved and help lead that effort. So thank you.